We're going to shift gears to the emerging models of care, which will be moderated by Bob Kerns. Dr. Kerns is a professor of psychiatry, neurology, and psychology at Yale University. He recently retired from VA Connecticut healthcare system and service to the Department of Veterans Affairs year a nearly 38-year career, during which time he served as VACHS Chief of Psychology, Founding Director of the Pain Research, Informatics, Multimorbidities, and Education Center of Innovation, and as VA National Program Director for Pain Management. So I'll turn it over to you, Bob.
Yeah, that introduction took 2 minutes. So I'm delighted to be here, and I also want to thank the organizers for inviting me to moderate this session. I'm going to provide an overview, and I'm actually note that I have some charges that are printed in the program. I'm going to cover deficiencies in current models, principles guiding development of new models, evidence for effectiveness of major models, and challenges for implementing in diverse settings. There we go. Those are my disclosures. Multiple sources of funding, a couple of paid honoraria, but I don't think anything particularly relevant. So I was very privileged to serve on the Institute of Medicine committee that produced a report that was kind of foundational for a follow-up initiative, the national development of a national pain strategy, and I was privileged to co-chair a chapter section on service delivery and payment. And this really highlighted the challenges that I think we're all pointing to here, that many challenges exist for accessing high-quality pain care, which is often not evidence-based, not team-based. It's limited to pharmacologic treatment delivered by a single provider in a single setting, and it's usually procedure-oriented and highly incentivized for specialty care. We need more quality research on the effectiveness of pain interventions, but particularly integrated models of care and reimbursement innovations. And we need more effective strategies for disseminating and promoting uptake of these findings into routine clinical practice. This has been the mantra this morning. We need to, I think, acknowledge right off the bat what Dennis, I think, was starting to allude to, which is that people with pain have multiple pain conditions, as best exemplified by an NIH and others, Chronic Pain Research Alliance concept of chronic overlapping pain conditions. In our research in the VA, for low back pain, the average number of pain conditions is about 3 for people in our chronic low back pain trials. Beyond the high co-prevalence of multiple pain conditions, of course, there are multiple other medical conditions, medical multimorbidities, as well as, and in particular, mental health and substance use disorder comorbidities. Data from the VA in a small sample of veterans who were seen in a specialty clinic to evaluate them as a follow-up to screening positive for traumatic brain injury, found that indeed a large proportion had traumatic brain injury and comorbid PTSD, post-traumatic stress disorder, but the largest proportion, nearly 50%, 42%, had not only PTSD and TBI, but also chronic pain. And so this exemplifies what we all know, which is the high co-prevalence of major depressive disorder, anxiety disorder, PTSD, substance use disorders as well. So we, in the National Pain Strategy, really the IOM committee report, promoted this concept of integrated, patient-centered, evidence-based, multimodal, interdisciplinary care. And that's really what I think this section of the program today will be talking about. So from the National Pain Strategy, integrative care is a systematic coordination of medical, psychological, and social aspects of healthcare and includes primary care, mental health care, and when needed, specialty care. And we can talk about even articulated, published outlines at least of a variety of models of care that might fit this bill of a model of integrated care, including step care, which is the VA and DoD's single standard of care, but also risk stratification models, matched care, collaborative care, care management, integrated care, and in a co-located setting, use of telecare, technology-assisted care, peer-delivered care by informal caregivers, and in the VA, as Ben Kligler will talk about, the whole health care initiative that promotes the uptake of complementary and integrative health approaches in particular. And there are other emerging models of care that we'll be talking about today. Having said this, there are challenges to this idea of is really interdisciplinary multimodal pain care the gold standard? A paper published recently in the journal Pain outlined a broader view of, or maybe expanded view of what we think about as kind of key ingredients of these models of integrated care, and outlined a research agenda that I think we'll be talking about today. I don't need to read them to you. They're all the topics that we're going to be highlighting in the series of presentations today. But what is the evidence, really, for this kind of approach of multimodal care? In the context of this preparation for a VA HSR, Health Services Research and Development sponsored state-of-the-art conference on non-pharmacologic approaches to pain management, a paper or a study was commissioned by the VA's evidence synthesis program, led by a multidisciplinary team, and published ultimately in a special issue of the Journal of General Internal Medicine of the proceedings and other studies related to that state-of-the-art conference. They conducted an evidence synthesis review and found, in fact, 11 articles of 10 studies that met their inclusion-exclusion criteria for mostly randomized controlled trials of different models of care delivery as opposed to single intervention approaches. And they had a list of the kind of approaches or models that they would study. They mostly reflect on the list that I provided 2 slides earlier. Most studies were RCTs of fair to good quality. Most had 12-month follow-up. Most had a usual care or some similar kind of control condition. To give you an idea of the patients included in these trials, their mean pain intensity was in the moderate to severe level of pain intensity on a 0 to 10 numeric rating scale. 9 diverse models of care were examined, and in fact, they showed evidence across these studies of that they were all, I guess, as a whole, contributing to a robust evidence of improvements in pain intensity and pain-related functioning or functional impairment. I think the most important aspect of this study was to highlight kind of 4 key ingredients of the puzzle, if you will, for an effective model of care. Decision support, to enhance provider education and treatment planning, so tools at the point of care, for example. Additional care coordination resources, I would highlight that in particular. Across these studies, care coordination loomed large. Improving patient education and models that promoted patient activation and empowerment seemed to be key. And also increasing access to multimodal care. That is, through these models of care, they themselves were delivering multimodal care or improving access to care. And I want to highlight 2 studies, again, primarily done in the VA. One was a study by Steve Dobshin and his team at Portland, Oregon Health Sciences Center, of an assistance for pain treatment, APT, versus treatment as usual care situation. They had engaged 42 primary care providers and over 400 patients, they had multiple measures of pain intensity and pain functioning, and the intervention itself included clinician education, patient assessment, education and activation, symptom monitoring, feedback and recommendations, and facilitation of specialty care. And literally, it was a care coordination kind of intervention with a heavy dose of clinician education. And in fact, they found significant improvements on all three measures of pain intensity and functioning relative to treatment as usual. This was published in JAMA in 2009. In the same time frame, a second study led by Kurt Kroenke and his team at Rodebush VA in Indianapolis and the Regent Strife Institute in Indiana University School of Medicine, SCAMP trial, step care for affective disorders and musculoskeletal pain. Here I'm highlighting the idea of looking at pain and, in this case, a single comorbidity, major depressive disorder. So 12 weeks of optimized antidepressant therapy, 6 sessions of largely phone-based, designed to be in person, but mostly phone-delivered pain self-management, CBT-like intervention, and 6 months continuation, 250 patients, multiple measures of pain intensity, pain functioning, and diagnosed major depressive disorder and depressive symptoms. And you see here, again, SCAMP relative to usual care had significant effects, particularly robust effects on the depression outcomes and less robust effects on pain intensity. Of course, this is all great news that we have some foundational understanding of models of care. We have a theoretical conceptual framework. We understand something about what may be some of the key ingredients. We have evidence building to support the efficacy and effectiveness, maybe even moving in the direction of cost effectiveness of these kinds of approaches. But in fact, we can then turn our attention to the issue of whether this is really available, these kinds of services are really available to people in our country. And I highlight here just a very recent MMWR, Morbidity and Mortality Weekly Report published by the CDC. It's a little bit of a stretch to present these data in this context, but what I love about this is highlighting the social determinants of pain and high-impact chronic pain that we've started to talk about today, pain that affects people's functioning, daily functioning and work-related activities and functioning over the recent 3 to 6 months. There's this MMWR reported on a very high prevalence of both chronic pain and high-impact chronic pain, and after adjusting for age, highlighted important social determinants of both chronic pain and high-impact chronic pain. So after adjusting for age, prevalence of both chronic pain and high-impact chronic pain are higher among women, those previously but not currently employed, less educated persons, those living in or near poverty, those living in rural settings, those with public health insurance. Well, you can read the slide. There's a qualifier here. And after adjusting for age, that prevalence of chronic pain was also higher among non-Hispanic whites and veterans. The reason for pointing out here is if you look at this list of disadvantaged people in terms of prevalence of chronic pain and high-impact chronic pain, they're also the same groups of people that potentially are disadvantaged in terms of accessing high-quality pain care as we see it or envision it. And this further emphasizes this. I think the big issue is the money and who's paying for what. And this is also a very recently published analysis by Hayward et al., published in JAMA Network Open just last month or the month before, I think September maybe. And really what the slide says it all, that there's great variance in coverage across the kinds of modalities that we would think or envision to be part of an integrative approach to an effective approach to chronic pain management. In particular, I'd highlight the limited coverage for acupuncture in this study, and particularly my thing, which is psychological interventions. Only 3 of 15 Medicaid plans that were examined in this study provided coverage for evidence-based psychological treatments for chronic non-cancer pain. And then beyond the issue of complexities related to multimorbidities and issues of disadvantaged populations, we have the challenge that we've also started to talk about here today about the population, the issues of promoting or implementing these kinds of models of care in our healthcare, in different healthcare settings and systems of care. We could talk about the VA and DoD, and as Ben Kliegler already highlighted, we're doing it in VA. Is it possible to do what we're doing in VA in private practice community settings, or some of these kind of mid-grade areas between highly integrated healthcare systems and the private practice community setting? And I would say that this other slide on the figure on the right says, yes, in VA we're promoting uptake of these kinds of approaches, and yet there's great room for improvement. And I would say across VA, thousands of points of access, there's huge variance across the system. So as is true for my grandson Jonah, there's lots of work to be done in terms of learning to read, learning to eat, and I would say the same is the challenge for us in this room, and I thank you very much.